Logistic and Organization team under the SANS Medical Student Chapter, and I am joined today with my co-head Payam Sido. In recognition of Spine Awareness Month, it's our honor to introduce our esteemed guest speaker, Dr. Mohammad Alshardan, consultant spine neurosurgeon at the National Neuroscience Institute, King Fahd Medical City in Riyadh. Dr. Alshardan completed his neurosurgery residency at the University of Ottawa and is certified by the Royal College of Physicians and Surgeons of Canada. His clinical expertise encompasses complex spinal disorders, including degenerative spine diseases, spinal tumors, and minimally invasive spinal procedures. Alongside his clinical responsibilities, Dr. Alshardan is actively involved in neurosurgical research, with multiple peer-reviewed publication and ongoing investigation focusing on spinal pathology, operative technique, and patient outcome metrics. He currently serves as a board member of the Saudi Association of Neurological Surgery for the 2025 to 2028 term and supervise the SANS Medical Student Chapter. Please join me in welcoming Dr. Mohammad Alshardan. We're very excited to learn from your expertise this evening. Dr. Alshardan, the floor is yours.
Assalamu alaikum.
Wa alaikum salam.
I'm very glad to be here today to discuss the first of this series of webinars, and I'm very appreciative of all the students' work to get this series running. It was a lot of work, and I know the struggle that you guys had to do it. So thank you very much for inviting me, and we'll talk today about the degenerative spine diseases. It's a big topic, so I'll try to be fast, and I'll try to talk a small. I'll try to approach each part of the spine and degenerative spine diseases, maybe on a superficial level, and maybe in later dates we can do it in a deeper level. If you allow me about 5 minutes, I'm just on call, so I'll just answer this call and get back to the lecture. Sorry about that. So our topic is degenerative spine diseases. I have nothing to disclose, not yet. Wait for me. Maybe I'll be a consultant in a big company and have a lot of money, then I'll disclose something. So what we'll talk today about is spinal anatomy in brief, since I believe that all of you as medical students or juniors are more familiar with spine anatomy and you're more fresh about it. We'll talk about the spine biomechanics, and then we'll talk about the three major things that's in degenerative spine: in the cervical myelopathy, thoracic disc herniation, and lumbar disc disease, either radicular or neurogenic. So in spinal anatomy, I like to divide it into these 5 groups. You have the cranial cervical junction by itself. It's have a unique anatomy, a lot of ligaments, and that's what we should think about. Then we have the subaxial spine anatomy. Then we have the thoracic spine. There's a bit of differentiation between the upper thoracic and the lower two vertebrae of thoracic, but in general, it's very similar. And then we have the lumbar spine and the sacrum. So, giving the complexity of the spine, I think the one that most difficult one to remember is the craniocervical junction, and that's what we'll spend some time on it. So, in the craniocervical junction, we have multiple joints. We have the atlanto-occipital joint, which is a synovial joint between the occipit condyles and the superior surface of the lateral masses of the C1. Then we have the atlantoaxial joints, which are three joints. We have one between the dens and the C1 arch. And then we have two between the lateral masses of the C1 and C2. The ligaments in the craniocervical junction there are many ligaments, so we'll talk about them. We have the anterior atlanto-occipital membrane, and we have the posterior atlanto-occipital membrane. The anterior atlanto-occipital membrane is a continuation of the anterior longitudinal ligament, and it's the membrane that connects the anterior arch of this C1 to the anterior margin of the foramen magnum. The posterior atlanto-occipital membrane, it's similar to ligamentum flavum, and connects the posterior arch of C1 to the posterior margin of the foramen magnum. Then we have the apical ligament, which is a median placed structure, connects the apex of the odontoid to the anterior margin of the foramen magnum. We have the alar ligament, which lies on each side of the apical ligament and connects the odontoid process to the medial sides of the condyles. Then they have cruciate ligament, which holds the odontoid to the C1. It has a transverse part and a vertical part, and binds odontoid to the C1. Then we have the tectorial membrane, which an abort continuation of the posterior longitudinal ligament and cover the posterior surface of the odontoid process. So here, picture is better than me talking. So you can see this is an anterior view. You can see in it the C1. Maybe I have to put the laser here. Let's see if we can put the laser pointer. Yeah, so we have the C1. Then we have this is C2. Then we can see this is the capsule of the C1, C2 lateral mass. This is the lateral masses, and this is the synovial membrane. And we can also see the anterior atlanto-occipital membrane, which is here. We have the capsule of the condyle and the atlas membrane. And this is a part of the posterior atlanto-occipital membrane, but you can't see it very well here. This is the posterior view, and this is the posterior arch of C1. This is the lamina of C2, and here you have the ligamentum flavum between C1 and C2, and between C1 and the occipit is the posterior atlanto-occipital membrane. We don't have much more to talk about in this anatomy. Again, the upper cervical spine is unique. The C1, C2, the atlas is not as the subaxial views. On the C1, it's an arch without a body, and it has two large lateral masses, and has a transverse foramen to pass the vertebral arch. C2 has a dense, and it has upper articulating surface, lower articulating surface, and also the head transverse process. This is the inside view of the cruciate ligament and the apical ligament and the alar ligament. It holds the dens to the arch of C1 and holds the dens to the foramen magnum. So this is why I wanted to focus on this. The rest of the spine, I think it's very easy to read, and there's no much to talk about it. I'll move now to the biomechanics of the spine. In the biomechanics of the spine, why it's important. Understanding the biomechanics of the spine, I think, is one of the major pitfalls of spine surgeon and neurosurgeons, because what we do, we interfere with the spine, we change the biomechanics, and sometimes if you change the biomechanics without really understanding what you're doing, you'll cause more harm than benefit. So why it's not moving? Yes. So we have multiple lines that we talk about in the spine. The idea of the spine, that we want the head to be inside the pelvis. So if you set up straight or standing up straight, you want the head, if you have an aerial view, you want to see the cranium inside the pelvis. Why is that important? Because of a concept called the cone of economy. A cone of economy is that determine that if your head is inside your pelvis, this is the least amount of energy produced by your spine to hold it upright. If you move forward, then you have more stress on your lumbar and thoracic spine, and if you move backwards, you have more stress on your pelvis. So you're trying to have the cone of economy centered this head inside the pelvis. And to do that, they came up with multiple lines. The basic ones are the sagittal balance lines. It's called the sagittal plumb line, which is a line that a drop line from the body of C7 going down vertically to the floor and on a scoliosis series. And if that line is within 5 centimeters of the posterior aspect of the end plate of S1, that means that you are balanced, or that's what's normal. So you have normal is plus minus 5. Positive balance is more than 5 centimeter. Negative balance is less than 5 centimeter. But in a lot of cases, especially in young patients, they will try to correct that problem even if they have a problem in their lumbar spine that should make them imbalanced. So a patient can be balanced or imbalanced. That same patient, if he's imbalanced, could be having a compensatory mechanism or decompensating. What are the compensatory mechanisms? Compensatory mechanisms are very simple. So you have a patient with loss of lumbar lordosis. So he's supposed to lean forward. To prevent that from happening, he will have his back straightened, so he will have hypokyphosis of his thoracic spine. If that doesn't work, he will retrovert his pelvis, so he will push his pelvis forward to get himself back. If that doesn't work, he will bend his knees. If that doesn't work, he will arc his ankles. So multiple compensatory mechanism that physiologically to keep the patient inside that cone of economy. So when we look at that, the spinal alignment, we have a local alignment and we have a global alignment. The global alignment, what we talked about, the plumb line. The local alignment are, we have a cervical lordosis. It should be 40 plus minus 9. We have the proximal thoracic, should be kyphotic. The thoracic spine itself from T5 to T12 is kyphosis between 20 to 50. Thoracolumbar area is the junction is between 3 to 0. And then we have the lumbar lordosis between L1 to S1 is 31 to 79. This is a big range. Why this is a big range? Because the lumbar lordosis depends on the pelvic incidence. So the lumbar lordosis should be equals to pelvic incidence plus minus 10, or pelvic incidence equals to lumbar lordosis plus minus 10. Then you have the pelvic tilt and sacral slope together, they equal the pelvic incidence. So here we talked about the pelvic incidence does not change with compensatory mechanism, though some studies now have been talking about that and there's some changes in it, but as a general rule, pelvic incidence is a constant, does not change, and it should, in a normal patient, should have should be equals to lumbar lordosis plus minus 9 or plus minus 10. If there is a mismatch between the lumbar lordosis and the pelvic incidence, let's say the pelvic incidence is 55 and the lumbar lordosis between L1 and S1 is 30 or 20, then there's a mismatch. That means this patient is imbalanced. Even if his plumb line is straight and within the 5 centimeters, that means that this patient is compensating for his mismatch. So this is the compensating mechanism. You either get hyperlordotic of lumbar spine or hypokyphosis of the thoracic spine. You get increase in the pelvic tilt, decrease in the sacral slope, flexion of the knee, and flexion of the ankle. Rassouli is a surgeon from France, has classified the spine into 4 groups or 4 types. So all of these 4 are normal. So some patients are born with less curvature of their spine, like type 2 and type 3. Some patients, they have more curvature of their spine, like type 4 and type 1. And that depends on the sacral slope. So sacral slope here is steep, and you can see the sacral slope is getting less and less and less. So if the sacral slope is steep, the lumbar lordosis will be bigger to have a balanced spine. If the sacral slope is almost flat, then your lumbar lordosis will be almost flat, and you have hyperkyphosis. All of this is normal. So type 1, you have a sacral slope less than 35. So they have low pelvic incidence, and the apex of the lumbar lordosis is really down at L5. Then you have type 2, they have also a low sacral slope, but their apex of the lumbar lordosis is at L4, at the bottom of L4. Type 3, higher sacral slope, 35 to 45, and then the apex of the lumbar lordosis is the level of L4. And you have a higher sacral slope, and the apex is the bottom of L3. So that's the 4 types of normal spine alignment. Why is that helpful? Why do we care about this? Because when you have a patient with abnormal degenerative spine disease and you want to fuse them, you want to fuse them in the most physiological, anatomical way of that specific patient. So you don't want to give someone with type 1 a lot of lordosis at the level of L3. At the same time, you want to give the type 4 apex at L3. So you might have a longer construct to keep the patients balanced. So here's the plumb line. From the body of C7, we drop a line all the way down. Then we measure from the back of S1, from the superior posterior end plate of S1 to that line, and it should be within 5 centimeters. This is normal, and this is almost normal. He's 53 centimeters. The pelvic incidence, how do we measure it? We have the femur head on that X-ray. So the femur head is here. We draw a line to the mid sacrum, then a 90-degree angle to the sacrum is this other line, and this angle is the pelvic incidence. The pelvic tilt is a vertical line to the femur head, then another line to the mid sacrum. This angle is the pelvic tilt. Sacral slope is a line on the end plate and then a horizontal line, and this angle is the sacral slope. How do you measure the lumbar lordosis? Is by drawing a line from the superior end plate of L1 and another line from the superior end plate of S1. It's called cup angle, and the angle between these two is the lumbar lordosis. So this is a practical guide that I made for myself. So when I see a patient, I do a C7 plumb line. If the C7 plumb line is normal, that means one of two things. Either the patient is really normal, there's no lumbar lordosis or pelvic incidence mismatch, so they might have a disc disease or anything. I will treat them as is without a problem. Can someone mute Ahmed? The other option is having this patient is normal C7 plumb line, but he's compensating by hypokyphosing his thoracic spine or tilting his hip. So I will know that by looking at the lumbar lordosis PI mismatch. So I will measure the PI lumbar lordosis mismatch, and I will measure the sacral slope and the pelvic tilt to know what kind of Rasuli subtype. Then I will decide how much correction do I need. Do I need to do a 20-degree lordosis construct, or do I need to do 30? Do I need to do 40? And depends on how much correction do I need to do, I'll plan my surgery, because there's so many different types of osteotomy that we can do for the patients. So osteotomies are done in this scheme. There's 6 types by Dr. Schwab, who described these 6 types. The first type is only partial facet resection. Type 2 is a complete facet resection. Type 3 is pedicle subtraction osteotomy. Type 4 is pedicle subtraction plus taking the upper disc. Type 5 is vertebrectomy, so taking the upper disc, the lower disc, and shortening procedure, taking the entire vertebrae. Type 6 is more than one vertebrae and their discs. This is a classification again with the description of it. So, doing all this measurement, does this exercise help the patient doing better after surgery? So, does realignment help with clinical outcome? Does realignment decrease or prevent mechanical failures? Or when do we need to screen for misalignment for everyone? So this is an older article, deformity correction surgery for primary degenerative sagittal imbalance. There's a meta-analysis. It showed there is a improvement in the ODI and the VAS score. It also shows the SVA, the sagittal vertical axis or the plumb line, is maintained after 2 years, and it is very helpful for the pain, but they did not show that's helpful in the revision. There's a follow-up article on this showing that it's helpful for revisions. So again, in this one, it showed that the post-operative VAS is better for leg and back at 2 years follow-up. So does it decrease or prevent mechanical failure? That's the 2 articles that showed that it does not. But again, there's so many critique on them and their methodology. But again, it showed that both patients, Group A and Group 1A, both had revision surgery because of BGK. So do we need to screen for misalignment in everyone? I think if you are fusing someone at the L5S1 level or doing multiple level fusion, you should screen for misalignment. Otherwise, I think you're doing the patient disservice. Okay, so now we're done with the biomechanics. How many times we've been talking? Any questions? We can stop for 5 minutes for questions, then we go to the pathophysiology of other things.
ايش قالت؟ شكرا على ايه؟ اوكي.
So رغد الحبشي, what's not clear?
she was mentioning الميجرمنتس اللي في البداية، اللي البلفيك انسيدنس والبلم لاين.
Okay,
ايه هذيك كان السؤال هناك.
let's go back to how to measure, right? So plumb line.
I
You see
think
this?
اللي قبلها شوي، في قبلها شيء.
These ones?
قبل ذولي، قبل رسولي، ايوه قبل. يس هذه
This
هذه
is
يس.
this is the numbers of the spine general rule of how much lordosis in the cervical spine, how much kyphosis that we're expecting. So if you see someone and you haven't done the measurement, you're expecting them to be somewhere in the 40s for their cervical lordosis, somewhere in the 20 to 50 for their kyphosis, depends on their compensating or what type of Rasuli subgroup. But in the thoracolumbar junction, T10 to L2, this junction itself should be between 3 to 0. So it shouldn't be kyphotic. And the lordosis, again, as we said, depends on Rasuli subtype and could be between 31 to 79. Is that clear?
اي I believe انه بعد ما اخذنا اللي بعده it was clear.
Okay. Anyone, feel free to ask questions.
بس I have a question دكتور. انت في السؤال الثالث كان انه should we screen؟
Should we screen?
اي وانت you said no الا اذا كان في fusion في ال L5S1 او انه multi level fusion. طيب باقي المرضى why not screen؟
There's no reason why not. You can screen, but I don't think it's very useful. If you're doing discectomy, for example, and you find the patient is imbalanced, would you do a fusion to correct them? Maybe not. But if you are going to do a TLEF for L5S1 and the patient already have a kyphotic, a segmental kyphosis at L5S1, so they don't have a lot of angle there, you want to make sure that this patient is actually Rasuli type 1, so he has a flat sacrum, instead of he is supposed to be Rasuli type 4 and you're fusing him in that position, so his entire spine will fall forward. So fusion is a different game than only decompression, because sometimes there is a physiological misbalance or imbalance that happens to the patients when they have spinal stenosis. So they lean forward, the shopping cart sign, they lean forward to open up their spine. So if you do an X-ray for someone with neurogenic claudication, you'll find that they're imbalanced. But their imbalance is not because they have a stiff back. Their imbalance is because they are doing that to allow the blood flow to the nerve roots. How does the biomechanics will help in congenital kyphoscoliosis cases? Is it more helpful in degenerative cases? It is helpful in both cases. It used to be in scoliosis cases, kyphoscoliotic cases, that we care about the coronal imbalance, and that's what we correct. But more and more we find that the sagittal imbalance is as important to as the coronal imbalance. So we do both for congenital or idiopathic scoliosis. Sacralization or lumbarization of L5 vertebrae affect the PI or pelvic incidence or sacral slope measurement. It shouldn't. Usually the lumbarization or sacralization is unilateral, but still the same measurement. If compensated, how is it clinically detected? You can, some patient clinically, if they're compensated for a long time, they will have hip pain, they will have tight hip muscles, they might develop even arthritis in their hip or knees because of the compensation. Other than that, it's very difficult to detect it clinically without X-ray. Okay. We can move to the next part of this talk. Guys, please let me know because I'm gonna close the chat, so I'm not gonna see it. If someone has a question, you can stop me at any time and we can address the question. So, cervical disease. In cervical spine, we have one of two problems. Problem number one is a myelopathy cervical spine. Problem number two is a radicular pain from the cervical spine. Both of them happens because of degeneration of the disc most of the time, and sometimes hypertrophy of the ligament and the facet joint causing compression either on the spinal cord or on the nerve roots that's coming from the spinal cord. So what happens with this? So there's a pathophysiology of disc degeneration itself. I don't think I'll go into that in details, but there's a chronic compression on the spinal cord leading to ischemia. This ischemia will do two things for the patient: glutamate excitation, and that will lead to neuro and oligo loss, and then you have the endothelial cell damage. And there's a inflammatory cascade that happens after that and lead to upper limb dysfunction and gait deficit and spasticity. So you can see here in this diagram, there's a compression paracentral or central. The central will cause more ischemia than the paracentral one because there's intact venous and arterial supply, where the central will compress the venous and arterial blood flow. Both of them is the myelopathy is a vascular problem or blood irrigation problem more than the compression itself. In the paracentral disc herniation, you will have a local decrease of blood flow because of increase in the venous pressure that leads to decrease in the arterial inflow. Where in the central one, you have a more global ischemia. So what happens in myelopathy? It's the most common cause of spinal cord dysfunction in adult worldwide. It's number one cause of disability outside trauma. It depends on the trauma statistics in each country, but what's consistent among all countries is number one cause of adult disability. It happens because either by static compression or by dynamic compression of the spinal cord, and with that compression, there's a spinal cord tension that will lead to decreased blood flow as well. So it manifests in the sixth decade of life, people above 50s, and it's more in male than females. But again, this is States and Canada stats. We don't have a lot of stats in Saudi Arabia. It affects a lot of people, and I believe, I truly believe that there are more people than what we have discovered having spinal cord compression, having myelopathy without being detected, thinking that it's just part of life. So you can see cervical myelopathy, this is Dr. Wilson's work, is getting higher and higher and more recognized, more than subdural hematomas, more than brain tumors, more than acute traumatic spinal cord injury over the years. And it's been more detected and more recognized among people. So here's my break and my 2 cents on Imr al-Qais. Imr al-Qais is a Arabic poet who is the father of all poets in Arabic, and he said, أليس ورائي إن تراحت منيتي لزوم العصا تحنى عليه الأصابع. So I do believe that people in this region of the world think that getting old should lead to using the cane because you have imbalance, and having a forward gait because you have a lower spine or lumbar spine stenosis. And the way how he avoided this, he wanted to die early, so he died when he was young. But I don't think that's the what we should recommend as a physician. Now we have a screening programs, and we can figure out a myelopathy early on and treat it accordingly. So most of the patient will have some neck pain, but neck pain is very general. Everyone has neck pain. They get numbness or clumsy hand. They might feel the Lemret phenomena, which happens with flexion of the neck. It causes a electrical shock in the back of their spine. That Lemret phenomena happen from stretching of the spinal cord. If they get impaired gait, that they need to use a cane or use the handrails to walk, muscle weakness, especially hand muscle weakness, and bilateral arm paresthesia. So bilateral arm paresthesia is very concerning. If you see someone with this, you should look for other things before looking for carpal tunnel syndrome. On examination, they have hyperreflexia. The reflexes that we usually check for are biceps, triceps, brachioradialis, knee jerk. They have Hoffman sign. They get broad-based unstable gait, lower limb spasticity in advanced cases, bladder or bowel dysfunction, and upgoing plantar response. This is Lemret phenomena. It happens because there's a stretching of the spinal cord with flexion, and this stretching causes, with demyelinated spine, causes electrical shock in the back of the spine. One way to examine the patient, or part of the examination of myelopathy patients, is filling the MGOA questionnaire. So this is an Arabic version of it. This is the English version. So it's 4 questions. You ask about the upper extremities, how strong they are, the upper extremity question, lower extremity question, sensation, and sphincter dysfunction. So in the upper extremity, you want to grade them from 0 to 5. 0 having no ability to move their hands, 5 is normal. Usually you ask them, what I do usually is I ask them, how is your hand? Do you have any problem with your hand? He said, well, yeah, sometimes. Can you button your shirt? If he said yes, then I'll go to the to question after that. Do you find it difficult to use a spoon or a fork? If he said no, then I'll go to the one below it, and then no inability to move then the one above it and the one above it. So you try to find something in the middle and go above it and below it to find and make this a quick exam for the patient. So if the patient comes back from this myelopathy screening or this myelopathy scoring to be 15 to 17 or 12 to 14 or 0 to 11. So 15 to 17 is mild myelopathy, moderate myelopathy, or severe myelopathy. And this kind of scoring is very important to decide what to do with the patient. I'll talk about the mild and moderate and severe in the slide after this, but this is a quick review on the imaging. What we will find in degenerative spine, you find that changes of the vertebral bodies. You get kind of modic changes of the vertebral body, degeneration of the disc, a smaller disc, and disc bulge, either symmetrical or asymmetrical. And of the spinal cord, you can find either a signal in the spinal cord itself or myelomylacia. So in this picture, for example, you can see here's a faint signal on T2. This is a stronger signal on T2. So this likely is an edema. This one looks like more of a myelomalacia. C is a white bright signal. This looks like a myelomalacia. These are two myelomalacia. And on T1, it will be dark if it's myelomalacia. If it's edema, it probably be grayish, not black. Modic changes are like these ones on C. You can see changes in the body. So what's the guidelines of treating a patient with mild myelopathy? So those are the one with 15 to 17. Follow up and serial examination over every 3 months or 6 months is can be considered okay, although some more research found operating early on is better because potentially they will deteriorate. The reason why we want to follow up with them, some group of those patients will not get worse. So why do you expose them to unnecessary surgery? So here's an effectiveness of non-operative versus operative treatment for mild disease. There is no huge difference between the two groups over 3 years of follow-up. So when we send them to follow up after 3 months, we want them to follow up with us, not to lose follow up. So if someone is coming and you will never see him again, probably it's better to operate on them, or they're difficult to come for follow up and regular checks. Maybe it's safer to operate on them earlier. They should, when they come to your clinic, they should, or you should teach them about the symptoms and what does worsening means. And they should avoid any technical manipulation or actually any manual manipulation of the neck, and avoid high injury or high likelihood injuries in sports or things like that. In moderate group, or they're 12 to 14, those should be operated on, as well as the severe. What type of operation depends on the pathology. So multiple levels with osteophytes and adherent to the cord from anterior, maybe you go posterior. Discs, soft discs, 2 or 3 levels even, you can go from anterior. Some cases you need to do anterior and posterior because of multiple reasons. Stronger construct, you needed to address a problem in the anterior as well as there's another problem in the posterior. So is it effective to operate on patients? What we usually say to the patients, a success operation is leaving you as you are without any worsening, but the aim of the surgery is to prevent things from getting worse. Some studies showed that the mild will improve better than the moderate, and the moderate will improve better than the severe. So this is a Dr. Feeling's study, and it showed the neurograde here. The baseline for MGOA was 12. At 12 months, it became 15. So there's improvement, as well as in neurograde. Is there a medication? That's a lot of questions happens to see if there's a medication that helps with myelopathy. Riluzole was one of the medication that was tried and there were a clinical trial on it, multi-center placebo versus treatment, double-blinded study showed no difference, unfortunately. Okay, done with the cervical disc. We have questions. Let's see what link for registration answered. This is all about the, can we get PDF, the PDF file of the lecture? I don't think so. But finally, no chopstick questions. Yes, there's no, the Japanese Orthopedic Association has the original one with chopsticks. This is the modified one. We diagnose, what is it? We diagnose myelopathy depending on the radiological findings. Right. No, not right, Dr. Shammeri. Myelopathy is a clinical diagnosis. The MRI findings shows stenosis, but myelopathy should be a clinical diagnosis. Cervical myelopathy has upper motor neuron lesion and lower motor lesions. Yes, it has both, and clinical findings and imaging. There's white cord syndrome from sudden decompression of cervical disc considered a type of myelopathy. Usually it happens for someone who has a myelopathy for a long period of time, and once you remove this, there's a reperfusion of the spine causes injury by hyperirrigation of the spine. It's not a type of myelopathy, it's a type of spinal cord injury. The approaches. So approaches for cervical spine, it depends on the pathology. There's few ways to decide how to approach a cervical spine pathology. One of them is something called K-line. It's a line between the midpoint in the canal of C2 to the midpoint of the canal of C7, and if the pathology is posterior to it or goes beyond it, you should go anterior. If the pathology is anterior to it or doesn't cross that line, you can go posterior. Two, it depends on what do you need from the surgery. Do you want to correct the lordosis? So correcting the lordosis is better to be done by anterior approach than posterior approach. Three is age of the patient. Patients who are older, above 70 or 75, they have higher risk of having esophageal problems if you go anterior, so you try to go posterior. So there's multiple ways to decide. General rule, 3 levels can be done anterior, posterior, usually done anterior. More than 3 levels, usually done posterior, but there's no gold rule for this. Depends from case to case. Okay. Thoracic discs. Am I taking more than what I'm supposed to take of time, or how are we doing with time?
We're doing great, doctor. Take your time.
Okay. Thoracic discs. Thoracic discs are similar to a cervical spine disc because it's usually compressing on the spinal cord, so they will result in myelopathy, but thoracic myelopathy, so it's lower limb problem. A few tricks on thoracic discs. One, their physical exam, you'll find that they have hyperreflexia, upper motor neuron signs in the lower extremities, but normal upper extremities. You should do for all thoracic discs a CT scan. That's one of the tricks for thoracic discs because most of the thoracic discs are calcified, and you want to do a you want to do a CT scan to look at if there is anything that you're missing, because having a calcified disc is way different than having a normal disc to deal with. The other thing in the MRI, you want to check if it's central or paracentral, because that will help you in determining what kind of approach you deal with it. So approaches to the thoracic spine are multiple approaches. You can do a laminectomy, which is not good for discs at all, because you cannot manipulate the cord. You can't push the cord to the side to deal with the disc. Usually you can do a transpedicular approach to the disc, or cost to transversectomy. So you take the transverse process and the part of the rib, especially the rib head, or a lateral extracorporeal approach. So all these approaches to the thoracic spine are can be done, except laminectomy for disc. You shouldn't do a laminectomy for disc. This is again how much it allows you to get. So if you do a midline approach laminectomy, you cannot do anything for the anterior part. The disc is here, so you cannot touch it, because you cannot move the cord right or left. But if you do a transpedicular approach, you get up to 1/3 of this of the cord. So if the disc is lateral, maybe transpedicular or transfacet approach is good. If you do cost transversectomy, you can reach the midline. So if the disc is beyond midline, maybe you do bilateral cost transversectomy to get some of it from this side and some of it from this side. Or you do lateral extracorporeal or extracavitarial approach. Lumbar spine. The thoracic, we're done. Question about thoracic. Let's see what we have. Dr. Mohammad Sabah, fusing the spine does make the osteophyte regress in most of the cases. You are correct. A combination between upper motor and lower motor neuron signs in myelopathy, you find it when you have a compression on the foramen and a major compression on the spinal cord itself. Dr. Sarah Shammeri, which approach is safe and more effective? That's a debatable question. I like costotransversectomy because I'm trained to do it. My colleague likes transfacet approach. Everyone has a preference on the approach. The most effective and most safe approach is the one that you're trained and you know how to do it. The issue with laminectomy is that you cannot move the spinal cord, because the disc, there's a spinal cord here and there's a disc anterior to it. So when you do laminectomy from the back, you cannot reach unless you have to go, either you have to go through the spinal cord. So if we go back to this picture, you either have to go through the spinal cord to get to the disc area, or you have to push the spinal cord to the side to get to the disc. So laminectomy alone is not helpful. Okay. Lumbar degenerative disc disease. We'll talk about the pathophysiology of disc degeneration in brief. We'll talk about the pathophysiology of radiculopathy and the pathophysiology of neurogenic claudication, clinical presentation, and radiological findings. So disc degeneration is a normal aging process. All discs by age 60 would be degenerated. About a third of the people under 40 have degenerative disc disease. So it's a very common thing. If you see someone, if you go on the street and do an MRI for everyone walking without any pain, you'll find about 70 or 60% of them having some sort of degeneration of the spine. It's what I tell my patients, the same thing as wrinkles. You get wrinkles, everyone gets wrinkles, unless you're a Botox addict, but everyone gets wrinkles, everyone gets degenerative disc disease. So what happens? Why do we have that? You get the proteoglycan loss causes this desiccation. Then there's a collagen shift between type 2 to type 1. There's reduced disc trigger and resilience, and then you have annular micro tears and fissure will develop. Then the nucleus pulposus will herniate if it will herniate. There's a inflammatory process as well. You get TNF alpha, IL-1 beta. It will drive the chronic inflammation, and you get a nitric oxide causes oxidative damage and suppression of anabolic factor, which leads to increase in apoptosis, senescent or apoptosis, either one of them to the cells, so no regeneration. And then oxidative stress accelerate the degeneration. So a normal disc is avascular and aneural. If there's an annual tear, you might have some nervous supply. That's why you have discogenic pain. And the disc height alteration will change the biomechanics of the spine and will make more stress on the facet joint, will lead to a facet hypertrophy, and that will lead to a facetogenic pain. So there's changes in the end plate, modic types 1, 2, 3. This is a summary of what happens to the disc. You have a mechanical factors, smoking, aging, genetics, lead to decreased nutrient availability, structural changes, inflammation, and new innervation leading to discogenic pain. So lumbar radiculopathy is an inflammatory problem. It's an inflammatory problem. The nerve becomes hypersensitive and it became inflamed. This inflammation causes radicular pain. They looked at the patient who are operated versus conservative management. They found the patient who underwent operation after 6 weeks of symptoms, they did better than the one who did conservative management. Neurogenic claudication, there's a main trial. It's a vascular problem. So there is a decrease in the blood flow to the nerves. It happens when the spine is in lordotic position. So when you're upright or walking, upright straight or walking upright, not bending forward, there is hypertrophy of the facet and the lateral recess, letting the venous hypertrophy, decrease blood flow to the nerves, and with walking, demand more for electrical impulse and demands more for oxygen. There's no oxygen enough to goes to the nerves, and you get neurogenic claudication. You sit down for 2 minutes, you get blood flow again, and then you walk again for 100 or 200 meters, and you get the pain again. The main trial found that surgery is superior to physiotherapy. So for neurogenic claudication, the surgery is better, in my opinion, and should be offered earlier than in radicular pain. I think that's it for my talk. It took me 1 hour. Great. Any questions? Dr. Ragad Al-Hbeshi, why is it becoming more prevalent in young patients, the disc degeneration? I don't know. I don't know if it's becoming more prevalent or not. Are we more detecting? I don't think we have a study to prove that it's more prevalent, but if it's becoming more prevalent, probably it has something to do with lifestyle modification or smoking, but I'm not sure. There is a role in interleukin 6 in pathogenesis for radiculopathy, but I'm not sure what exactly the role. Thank you.
Okay, thank you once again, Dr. Alshardan, for this valuable and insightful session. We truly appreciate your time and effort in sharing your expertise with us. And thank you to everyone who joined us today. We hope you enjoyed it as much as we did. See you soon in our upcoming SANS Medical Student Chapter activities. Thank you.